Hi. This video demonstrates my heart disease prediction system implementation using a random forest model. I will walk through the dataset, processing steps, model implementation, evaluation results, and explain why this technique was chosen. In part B of the implementation, I have evaluated three different techniques: um, logistical regression, artificial neural networks, and random forest model. After comparing their strengths and limitations, random forest was selected as the final technique for this implementation. Logistic regression was useful as a base model due to its simplicity and ease of use, but it struggles to capture complex relationships between clinical features. Neural networks are powerful but require large datasets and are harder to interpret, which makes them less suitable for this project. Random Forest offers a good balance and it also handles nonlinear relationships well, performs reliably on structured medical data, and remains efficient without requiring specialized hardware. For these reasons, Random Forest is chosen as the most appropriate technique for this implementation. The data is downloaded from my GitHub repo if already not present and loaded from a CSV file which contains anonymous clinical information for individual patients. Each row presents a single patient and each column represents a clinical attribute such as age, blood pressure, cholesterol level, etc. The target column indicates whether heart disease is present or not, making this a supervised classification problem. I also perform basic checks to confirm the dataset size and ensure there are no missing values that could affect the model training. These steps help to verify the input data is valid and suitable for analysis. Next, we move on to training the data set. So here we split the data into training and testing subsets using stratified sampling. This ensures both subset contains a similar proportion of the patients with and without heart disease. The features are divided into numerical and categorical groups. Numerical features include values such as age and cholesterol, etc., while the categorical features describe conditions such as chest pain and exercise induced apnea. Since machine learning models require numerical input, categorical values are converted using one hot encoding. This creates binary indicators without introducing artificial ordering. Numerical features are scaled so that the differences in value range do not influence the model unfairly. All pre-processing steps are combined into a single pipeline, which ensures the same transformations are applied consistently during both training and testing, improving reliability and preventing data leakage. The model is trained using the training data to ensure reliability. Cross-validation is used during training so that performance does not depend on a single data split. Next, I evaluate the training model using the unseen test data. The first result shown is accuracy, which measures how many predictions were correct overall. The model achieves high accuracy, indicating strong overall performance. The confusion matrix provides more detailed insight. It shows how many patients were correctly identified as having heart disease, how many were correctly identified as not having heart disease, and where classification occurs. The number of incorrect predictions is relatively low, suggesting balanced performance. The ROC curve demonstrates how well the model separates high-risk patients from low-risk patients. A curve that remains close to the top left corner indicates strong discrimination. The precision recall curve further confirms that the model maintains a good balance between detecting heart disease case and avoiding false alarms. Together, these results show that the random forest model performs well on this dataset. In the context of healthcare, these results are meaningful in such way that the model is effective at identifying patients who may be at high risk of heart disease. This also means that this could help prioritize patients for further diagnostics, testing, or clinical review. Importantly, the system does not make final medical decisions. Instead, it provides supportive information that doctors can use alongside their professional judgment. The results also remain consistent across training, validation, and testing, which suggests the model generalized well and does not simply memorize the data. The main strengths of this implementation is reliability, strong predictive performance, and the use of data that is already available in a hospital setting. However, there are also limitations. The dataset is relatively small and comes from a limited population, which means the results may not generalize perfectly to all participant groups. Additionally, the model has not been tested on external hospital data. These limitations highlight area for future improvements, such as using larger and more diverse datasets. Thank you.